Well, the honor is really mine. Just checking, wait. I have one cartoon, one video, but I'm really not very tech savvy. I'd like to thank Dr. Madan and Dr. Don for the invitation. It's a pleasure to be here. I see a lot of friends and familiar faces. And I would like to give special thanks to Dr. Deppner, who's really been an inspiration in my career for basically since I was a fellow. So I took the liberty of modifying the title a little bit, and I changed the title to Contrast Nephropathy, Much Ado About Nothing, ? And here's a little cartoon for those stat nerds like me. I used to think correlation implied causation. Then I took a statistics class, now I don't. Sounds like the class helped. Well, maybe. So for my outline, we will have a valuable lesson from an intelligent president. A walk through modern nephrology history, compare and contrast several key publications. You get that pun, compare and contrast. Lessons not quite yet learned, and an evolution of nomenclature, which I think nephrologists are particularly poor at naming things. And I take some issue in that. So let's see if we can get this to work. This is a lesson from President Jed Bartlett. Hands free. I'm wholly at the mercy of our AV experts. Right-click and preview, I think. There is a point to this, actually. So did you hear the one about President Trump? I'm sorry. I will try to give you back a couple minutes toward the end here. So this really should work, and it makes an important point, which I can make, but not as well as Martin Sheen. It worked perfectly well with a right click and a preview. But if it doesn't work, I will tell you that I'll just give you the scene because I don't want to take too much time, unless I should do it here. So basically, they're all in the Oval Office, and CJ and Josh and Sam and Leo are in the Oval Office, and they start asking Jed Bartlett about why he lost Texas in the primary and in his first election, and he said, and CJ says, well, it's because you say you don't look good in funny hats. And then he says, no, I don't say funny hats, I just say big hats. And they argue a little bit about funny hats versus big hats. And then they basically talk for a couple of minutes about the reason why he didn't win the primary or the election in Texas. And then he says, of course, he was a Latin scholar. And he said, boy, we're devolving now. Don't even have the slides up. So he says, can anyone explain what post hoc ergo propter hoc means? And so Josh, of course, being the Westport, Connecticut born, Harvard-trained vice chief of staff, mumbles a little bit, and then, of course, Leo says, yes, of course, it means after this, therefore because of this. And Bartlett makes the point that he didn't lose Texas because he was wearing funny hat or big hat. And that's the point of the clip. So we can go back to the slides. Post hoc ergo propter hoc. I want you to remember that. I'm going to quiz you later. Kristen, you're up. So, forgive me for the technical mishap. So we're going to walk through some really key clinical trials, and these are three that we'll start with. Rick Solomon's paper from 1994 on the effects of saline, mannitol, and furosemide on acute decline in kidney function, the prevention of radiographic contrast agent induced nephropathy, this heinous paper from Teppel in 2000, and this follow-up paper about sodium bicarbonate. We'll talk a little bit about each of these. And the first paper by Solomon was really the first RCT about contrast nephropathy that was published in a very high-profile journal. And we'll give you just a summary. 78 patients with chronic renal insufficiency, which was the term, this was well before the term chronic kidney disease was developed. Mean serum creatinine 2.1, who underwent cardiac angiography. They were randomly assigned to receive half normal saline for 12 hours before and 12 hours after angiography, saline plus mannitol, and saline plus furosemide. And for those of you who were around back then, you might remember that the rationale for saline and mannitol was, well, you just flushed the crap out of the tubules. And furosemide would be you flushed the crap out of the tubules and you can reduce the energy expenditure of the transporters in the third section of the proximal tubule and the thick ascending limb. And so it's like a beta blocker for the kidney, reduced energy expenditure. That was the theory. So serum creatinine was measured before and 48 hours after angiography. They defined acute radiocontrast-induced decrease in renal function. So remember, we're going to think about nomenclature. So acute radiocontrast-induced decrease in renal function. Remember that. I'm going to quiz you on that too. Was defined as an increase in the baseline serum creatinine of 0.5 milligram per deciliter or more within 48 hours after the injection. And this is basically just a quick summary of the table 1 of the groups. So compared to most clinical trials that are published in this decade or the last decade, this is quite a small clinical trial, just a handful of patients, 73 patients. But they seem to be pretty evenly matched. And these are the plots of the serum creatinine before and 48 hours after angiography. And you can see that the saline group was pretty flat. On average, the mannitol group was a little bit elevated. The furosemide group was a little bit elevated. Those are the summary statistics. And the incidence of AKI, or the incidence of what they described as radiocontrast-induced decline in renal function, was, boy, I really need my glasses, was 11% in the saline group, 28% in the mannitol and saline group, and 40% in the furosemide and saline group. And so the difference between them across all three was statistically significant at the margin, 0.05, and the intergroup furosemide plus saline versus saline alone, that pairwise comparison was also statistically significant. And so the conclusion from that study was that saline infusion helps to lower the incidence of radiocontrast nephropathy, and in fact diuretics, with whatever rationale was put forward, was not helpful. Now the next paper, the heinous paper, it was 83 patients with chronic renal insufficiency undergoing CT with a non-ionic low osmolality contrast. Patients were randomly assigned either to receive the antioxidant N-acetylcysteine, 600 milligrams orally twice daily, and half normal saline before and after the administration of radiocontrast, or to receive placebo and saline. And how many of you were actually practicing when this trial was published? So just a couple. Boy, I'm getting old. And they similarly defined acute contrast agent. They called it acute contrast agent induced, lots of hyphens, reduction in renal function was similarly defined at 48 hours, an increase of 0.5 milligram per deciliter or more. And there was, despite its publication in the New England Journal in the 21st century, or I guess the very end of the 20th century, there was no power calculation. And these were the groups, again, like the Solomon study, the groups were pretty well balanced. Even though it was a small study, they were pretty well balanced, randomized, and no major differences between the groups. And this was the similar, really they just followed, 6 years later, they followed the same pattern, same tables, same figures, more or less, and showed here that in fact the serum creatinine before and after contrast, you can see there are a few more patients who are rising. The average serum creatinine was slightly positive, meaning slightly rising in the control group, the saline group, and was actually slightly declining in the N-acetylcysteine group. And there were fewer patients who had that acute rise. And this is the most phenomenal table ever published in the New England Journal, if you ask me. So this is the incidence of this acute reduction in renal function. And you see there was one patient among the 41 patients in the N-acetylcysteine group and 9 patients in the control group, the similar number, 9 out of 42. So there was about a 10-fold, 8 or 9, 10-fold increase in the risk, and this achieved a p-value of 0.01. Hooray! And it got published. Now, no power calculation. And, you know, fool me once, shame on you. Okay? The final analysis was conducted on an intention to treat, et cetera, et cetera, et cetera. Differences, but nothing about what was the estimated effect, nothing about the power, 83 patients. Now, let's take a minute and look. What was the relative risk seen in patients who were treated with N-acetylcysteine? It was about 0.1, meaning that there was basically a 90% treatment benefit. Now, I don't know anyone in the room who was around when sulfa antibiotics or penicillin was derived for pneumococcal pneumonia, but I don't know any treatment in American medicine that has a 90% treatment effect. Well, maybe the hepatitis C drugs, but aside from that, it's just not conceivable. Yet, Brian, you were in practice. What happened after this paper was published? Pardon me? It went viral. It absolutely went viral. So there was a follow-up paper a couple of years later, bicarbonate versus saline, a whole rationale about redox and iron and oxidative stress and so forth. 119 patients studied with a stable serum creatinine of over 1.1, so some degree of chronic kidney disease. Serum creatinine was measured at baseline and 1 and 2 days after radiocontrast exposure, and the patients received either isotonic sodium chloride or sodium bicarbonate, 3 ml per kilo per hour for 1 hour before, and then 1 ml per kilo per hour for 6 hours after. And this became a standard, soon after, a standard method of volume expansion. Contrast-induced nephropathy, I'm going to quiz you later, defined as an increase of 25% or more in serum creatinine within 2 days. So probably a smaller incremental change than the 0.5 milligram per deciliter in the first 2 trials. A sample size calculation was actually provided in the method, so this was a plus. And you can see again, this maybe doesn't, I'm not sure how well this is seen in the back because it's kind of lightly printed, but the group's a slightly larger study, 119 patients as opposed to 73 and 83. Also pretty well balanced, so nothing about the underlying allocation to different groups could explain the differences in effect. And this slide discusses a whole series of endpoints, change in a variety of different laboratory studies, contrast volume, et cetera. But I want you to focus on the incidence of contrast-induced nephropathy, which was calculated at 11.9% or 1.7%. So again, about an 8-fold reduction or an 8-fold difference in the treatment groups. And again, this achieves statistical significance. Again, another, following the pattern of the first 2 papers, you can see these in blue. You can see the patients who were treated with saline who experienced a rise in serum creatinine, and here there was just one patient who received, who experienced acute kidney injury treated with bicarbonate, and then a scatter plot looking at the persons who basically by the degree of elevation met the definition of the 25% increase in the serum creatinine. So are you seeing a consistent theme here? So now, fool me twice, shame on me. There is a 67% estimated treatment effect. If you read the methods, they estimated 15% incidence in the saline group and a 5% incidence in the bicarbonate group. Now, it's not, they didn't estimate a 90% treatment effect, but do you really think a 2/3 reduction of one mechanism of volume expansion versus another is a plausible treatment effect? I don't think so. The sample size that was required, if you read the paper, was 260. And that's with this hugely overestimated treatment effect. But then the published paper had 119 patients. Well, the trial was terminated by a safety monitor on ethical grounds. On ethical grounds. But there were no formal stopping rules, nothing formalized. And the subsequent patients, at least to their credit, were tracked. And interestingly enough, the patients who were tracked all and were receiving bicarbonate, because of course giving saline would have been unethical, were, also experienced a rate of acute contrast-induced nephropathy by their definition of about 2%. So I was asked to write an editorial, which I, in another pun, called Back to Basics. But basically, I think, it's funny when you read things that you wrote 15 years ago and you're like, ooh, I hope I didn't screw it up back then. But I basically said, although addressing a very specific clinical entity, the lessons learned can be broadly applied. Physicians should encourage the conduct of adequately powered clinical trials when facing uncertainty, which is most every day, most every hour, and should view studies with provocative yet preliminary results as hypothesis generating. Prospective confirmation should be required before broadly accepting new therapies into routine clinical practice. Brian, What happened after this paper was published? It kind of went viral. Not quite as viral as N-acetylcysteine, but it kind of went viral. So I just want to highlight a paper that nobody ever read, but I worked a long, long time on. And we published this paper, which we coined the term renalism, akin to ageism, sexism, racism. That is, that patients who have kidney disease are treated differently because they have kidney disease and for no other good reason. And what we basically showed, and this was from a large database of patients who were in something called the Cooperative Cardiovascular Project. It was a Medicare organized study in which patients post-MI were evaluated for quality of care issues. And there we go. What we showed was that the patients who had CKD, which we defined multiple ways, but initially based on the fact that they were data from the 1990s, we initially defined it as a creatinine greater than 1.5, because we figured that was a threshold at which people would maybe notice that the creatinine was elevated, and a radiologist might notice or a cardiologist might notice. No offense meant to the cardiologists or radiologists or the spouses of cardiologists and radiologists in the office. But we also defined it with more modern methods like the estimated GFR, et cetera. But what we found was that patients who had CKD had equal levels of appropriateness based on clinical practice guidelines from the American College of Cardiology and the American Heart Association, yet underwent coronary angiography about half as often as patients who did not have chronic kidney disease. And so that I figured that's not right. That's renalism. So people are not exposing patients to radiocontrast because of this irrational fear that they're going to have this terrible problem, this radiocontrast-induced nephropathy, and that it would not be counterbalanced by something that might help them, like identifying a 90% left main lesion and then undergoing coronary artery bypass grafting. So this is very imperfect. It's not a randomized clinical trial, but we did balance the patients using a method which wasn't used that commonly 15 years ago, but is much more commonly used now, called propensity score matching. And we basically found that the patients with chronic kidney disease who underwent coronary angiography after MI had a 38% lower risk of death at a year. So this fear that we have about inducing something because we're really worried about it could really have serious clinical consequences. So Miri, you're a scholar and you're in my line of sight. Do you remember the Latin words that unfortunately we couldn't hear from Jed Bartlett and you heard from me? Post hoc ergo propter hoc. Okay, remember that. So this issue of post hoc ergo propter hoc really motivated this study, which I think caused a lot of controversy. I actually made it onto the ASN bingo because of this study. It was published right around the time of ASN, and somebody said, if a fellow had an argument with me about radiocontrast nephropathy, he or she could X out one of the bingo sites on ASN bingo. But I'm serious. So we use something that used to be called the nationwide. Now it's been called, I don't know, this is the government national inpatient sample. We used a 2009 subset. For those of you who aren't familiar with the data set, it's a phenomenally powerful data set that at the time was a a sample, a 20% sample of hospitals throughout the country, other than, I think, non-VA and non-like alcohol rehab, but virtually every hospital was included in this, and 20% of the hospitals would be randomly selected each year. And you'd basically get an enormous amount of administrative data, meaning diagnosis codes, procedure codes, discharge dates, nothing that we would like as renal dietitians or nephrology nurses or nephrologists, but just a lot of codes. But we could see who was hospitalized and who had acute kidney injury, at least by codes. And we knew from some validation work we had done earlier that generally people with mild AKI, maybe what now goes by stage 1 AKI by KDIGO criteria, are not commonly coded as such. So maybe this represents an underestimate of the frequency of AKI and probably represents more serious, slightly more serious AKI. But we included basically all patients at least 18 years old at the time of admission, limited our study population to those hospitalizations 10 days or fewer, because one of the problems, as I'll review in a minute, is you know the date of the procedure, but you don't necessarily know the date that the AKI developed. So if someone had a procedure on hospital day 4 and had AKI that was coded on hospital day 74, it would be really hard to attribute that in any way to the radio contrast exposure. Now, some of the real important limitations of these data, and I love to do clinical trials. I also really enjoy observational research. It's sort of like making a silk purse from a sow's ear. It's when you can find data that, is imperfect, but you do your best to make something reasonably attractive with it. So this is administrative data, so there's no detailed clinical and especially laboratory data to identify what was our dependent variable, which was AKI, and the key independent variable, which is radio contrast exposure. So we didn't know if they got 200 mLs of radio contrast or 40 mLs of radio contrast, or what type of radio contrast it was, or if they got it twice or whatever. And we didn't have detailed data on other covariates. So heart failure in one patient isn't the same as heart failure in another patient. There's no severity metric really, or few. The data set contains only up to 25 diagnosis codes. So if someone's really complicated and has 40 diagnoses that are all coded, then we might run into some problems, and only up to 15 procedure codes for each hospitalization. So it's possible if they had 12 surgeries that a couple of radio contrast administrations would have been missed. And they have the procedure and diagnosis codes have no associated dates, preventing us from determining the sequence of events. Actually, the procedures, many of the procedure codes do. I'm not certain about the radio contrast procedure codes. There are no patient identifiers, which is another problem. So if someone is admitted 15 times in 2009 to a hospital that was selected into the NIS, then we might have counted a particular patient more than once. So technically speaking, the observations are not independent. I don't think it changes any of the qualitative interpretations, which I'll get to in a minute. This gives you a sense of the power, of the size. There were almost 8 million hospitalizations that were tracked, and with a few reasonable exclusions, we still ended up with about 6 million hospitalizations. And you can see that this very simply shows the incidence of AKI by diagnosis across the sample. It's about 5.5% of patients developed AKI within those hospitalizations that were 10 days or fewer. And interestingly, it was 5.6 in the patients who did not receive contrast and 5.5 in the patients who did receive contrast. I'm not suggesting, and for these, so we also stratified by a whole series of individual diagnoses. So we then took out people who were hospitalized, say, for coronary interventions or for sepsis or for pneumonia, so that would narrow the severity issues, and that would narrow some of the differences between groups. But I think the most striking thing that you see here is that there's an enormous amount of AKI that develops over the course of a hospitalization in sick patients. And it has nothing at all to do with, none of these people ever received a drop of radiocontrast, yet they had a lot of AKI. So these patients received radiocontrast, and they had AKI. So these are the politicians who lost Texas because they were wearing a big funny hat. Miri, post hoc, ergo propter hoc. And this shows it graphically. The patients who received contrast are in the plus signs. The patients who didn't are in the open circles. So you can see in some of the diseases, it looks like the patients who received radiocontrast had slightly higher risks of AKI. In other groups, they had slightly lower risks of AKI. I think among the most interesting ones is the acute coronary syndrome. So the patients who received radiocontrast and were diagnosed with, and were in the hospital for a primary diagnosis of ACS, were much less likely to develop AKI. Now, is that because radiocontrast is protective against AKI, or just that the doctors aren't doing angiography in the patients who are sick, and the doctors, aren't dumbos? So when I see these data, I'm not suggesting, as Burl introduced, that there is no such thing as radiocontrast nephropathy, but there's a lot of AKI that occurs without radiocontrast. And so when someone gets radiocontrast and we see AKI, and then we call it radiocontrast-induced AKI, we're completely idiotic. It's a logical fallacy, and we're failing. You guys are not up in arms. You're just... I'm like Bernie Sanders here. The world is ending. I don't have a super PAC. I don't even have a backpack. Anyway, so I'll end with this really elegantly done clinical trial that I have to... So I should say before we go on there that we were not the only people who looked at this issue. The radiologists, there were a couple of papers. A radiologist named McDonald published a couple of papers. They were very provocative and much less conservatively interpreted than I think we did. And nephrologists don't read, the Journal of Rentgenology or whatever. So, they read Jason, so people paid attention. But we'd thought about this for a long time, but there had been a couple of papers in the radiology literature that raised the question, how relevant is this? So here I have to say Steve Weisbord, who's a youngish faculty member at University of Pittsburgh, and Paul Pilevsky did a phenomenal job putting the PRESERVE trial together through the VA and with an international collaboration. And we did what I suggested we did in 2004, that is, we took provocative results, like the results from the heinous Teppel paper and the slightly less heinous Merton paper, and tested it in a large population of patients. And I won't go into all these details, but you see there were about 5,000 patients enrolled in the trial. The trial was terminated before there was full enrollment because it met one of the formal stopping rules. And as you might imagine, the stopping rule was a futility stopping rule. And so basically, again, this slide, and we don't need to go over this, but I guess these will be shared for the conference participants, but it basically shows that the groups were quite well balanced. So this was what we call a 2x2 factorial design, where people were randomized to either saline or bicarbonate infusion and either placebo or N-acetylcysteine. So there were really 4 groups, but they compared the 2 N-acetylcysteine groups versus the 2 placebo groups, and then the 2 saline groups versus the 2 bicarbonate groups. And then they also tested for interactions. And basically, this table shows that there's no effect. So all this viral, it was like a wildfire. N-acetylcysteine was a wildfire from Shattuck Street all the way to Sacramento. And so this is the conclusion from the paper Preserve, which was presented. Actually, the ASN declined this for a late-breaking clinical trial. And Steve Weisbord called me and he said, "Glenn, what should we do? They declined us. They told us we had a poster." I said, "A poster? You got to be kidding." I said, "Pull it from ASN, present it at the American Heart Association," which is what they did. And anyway, it was published same day at the New England Journal. But among patients at high risk for renal complications who are undergoing angiography, there was no benefit of intravenous sodium bicarbonate over intravenous saline or oral acetylcysteine. And if this is a really relevant clinical outcome, you're talking about death, need for dialysis, or a persistent decline in kidney function at 90 days. And if you remember the slides here, the primary endpoint was seen in about 4%, 4.5% of patients. And no difference between any of the 2 groups. Now, we didn't look at a group who got no hydration at all. Okay, so it's not really from the fluid side, it's not placebo controlled. But there's no magical 75% benefit from bicarbonate or 90% benefit from N-acetylcysteine. So another quiz. So who else can I pick on? Lorian. Who are these wise folk? I'll call them folk. They happen to be men, but we'll call them folk because there's so many wise women in the audience today. No. Michael? Okay. This is Daniel Kahneman, behavioral economist at Princeton University, and the late Amos Tversky, a behavioral economist at Stanford University, who unfortunately passed away before he could share the Nobel Prize in economics with his friend. The new Michael Lewis book describes their friendship and their lives, but they describe the behavioral heuristics that go into decision-making, much of their work was around medicine. And contrast, and forgive me, I know I'm a couple minutes over, but this is a perfect example of where we have, and their work has demonstrated this in multiple settings, where we make ill decisions, unwise decisions, because we're much more concerned about regret than we are about gain. And so we don't do radio contrast imaging because we have this concern that radio contrast is such an important problem and we don't want to harm people. And heaven forbid the radiologists or CT surgeons will give a patient acute renal failure. Well, the truth is they're going to get acute renal failure a lot of the time anyway. And I don't want to have a festering abscess in the abdomen for 3 more days while I wait to give a patient N-acetylcysteine or give them heart failure by giving them 3 liters of saline. So where are we these 25 years that have basically spanned my career as a clinical nephrologist? We've had 25 years of clinical trials, 25 years of the logical fallacy. One more chance, Mary. Anyone, say it aloud, say it together. Post hoc, ergo propter hoc. Excellent. Hundreds, and you know, there are enormous opportunity costs to this work. Now, for those of you who've done acute kidney injury research over the years, this was the clinical model for testing new drugs, old drugs and new drugs. There were many failed trials of phenoldiprem, dopamine, diuretics, endothelin antagonists, a whole host of them. Hundreds of millions of dollars of wasted resources and research that could have gone, instead of preventing something that, in my opinion, it's not that it doesn't exist, but it's much ado about nothing. And we've seen foolish paths toward new drug development. How many, I know there are some pharmaceutical executives and representatives in the audience, how many millions of dollars have been wasted trying to develop drugs for kidney disease that were given to people to prevent something that is barely recognizable? And we've evolved in nomenclature, and I've been pushing, and so in this paper for the New England Journal, I said, Steve, do not call this contrast-induced nephropathy. Call it contrast-associated nephropathy, if you wish, but don't call it contrast-induced. And so I ask you, is it a major cause of AKI or much ado about nothing? Thank you for your attention.